Everybody back. We now are heading into the third session of today. I hope you've had some time to rest, breathe. We are inviting you to continue to do the messy work, as we said to those who started with us in session one. One of the panelists said the work that we are doing in patient engagement is messy, and I love that. It's good trouble that we are causing. I encourage you all, the audience, to please put your questions in the question and answers. And it is my pleasure to hand over to your moderator for this session, Knoll Larkin. Enjoy.
Hello, welcome everyone. Thank you so much. My name is Knoll Larkin. I'll share a little bit more about me later, but I'm a liaison. I identify as a patient partner as well as a facilitator of patient engagement and a research staff member. But I'm also going to present, so I'll share a little bit more about that with you later. I want to let everyone know who's in the audience today that this is our Building Capacity on Research Teams session, and we're here to help strengthen the overall team. And so I'm also here with BC and Rachel. So we're very excited to have everyone here. This session includes people who are patient partners and who have different professional and volunteer roles in the research space as well. So we're going to share resources and tools that we've all worked on to help research teams work better together. So I want to let you know that there's going to be 3 talks today in the session, followed by a Q&A. And each speaker is going to share a little bit about themselves before they speak. And we have bios of the speakers are going to be found in a link that will be shared in the chat. So without further ado, I'm going to hand it over to Rachel to get us started.
Thank you so much, Knoll. Now I'm really excited to be here. So first I'm going to do that exciting moment of sharing my screen. Let's hope that it all goes well. It worked well in the, here we go. So kicking off a little bit about myself, I will make this into presentation mode. There we go. Can you see that okay?
Rachel, we can still see your presenter mode.
It worked last time. I'm not sure what to do.
Right.
Classic. Let me see. I'm going to go back. We tried this already and it was fixed. So I'm going to stop share and try it again. Share. Anyway, I'll just start talking about myself and we'll see how if this clicks up okay. So my name is Rachel Giles. I'm based in Amsterdam, and my professional position as the patient engagement director at a think tank. It's a European think tank called Patficates. Perhaps some of you are familiar with it, and we do all sorts of work to promote patient engagement. But in my free time as a volunteer, I'm a cancer patient advocate. I run a European organization called VHL Europa, and I work on many different levels at the European level. And I was asked to come here today to speak a little bit about something that we promote called evidence-based advocacy. So firstly, I think just to get us all on the same page, and I'm the first speaker of this session, I just want to remind you, we are all advocates, and very rarely do you ever hear someone choose patient advocacy as a career choice, because typically you have to become a patient first, or your partners become a patient, or your child's become a patient. And in general, what we do as patient advocates is we try and support people with health conditions. That can be done in different ways. We also support the medical community, reach their goals as well, and improve research, for example. And we try to influence regulators and payers to support the patient community in whatever we think is the right priorities. And we like to tell politicians how to do their work, that we want them to do the policy for us. And we're excited to help them in their roads as well. So indeed, so the chairs are in a circle. Generally, patient organizations begin with a peer-to-peer support system. This is an integral part of patient engagement and starting that process. However, next slide, please. So patient organizations, also function at 3 different levels. And so they work at the local, national level, and they can do that in a patient peer-to-peer support system. They can do that in local health policy, for example, on hospital boards, or they can do that in research at their local clinic or working in national research questions and so forth. Likewise, they work at the European level. At least I'm based in Europe, so I'm using this as an example, but it can be any regional aspect and globally. And we work to influence EU policy. We build frameworks. We work in health policy spaces. We talk with the members of parliament and so forth. And we're very involved in European research grants. And lastly, global initiatives are also taken steadily more in place, and these include the European-based organizations, but also they involve Asian and South American, North American, and oceanic groups as well. And so that is a different type of advocacy altogether, but it's equally valid and very important. Next slide, please. One important point to make is that although each patient organization most of them start with peer-to-peer support, which is shown in this very left green bubble here. They generally evolve over time, and sometimes they may become involved in research questions, and they are working on drug approval sometimes or clinical trial design. And then later on, they may be involved in, say, the HTA process or more advanced research issues that involve patient experience data. But the problem is most of us are not trained scientists, and this requires a fairly advanced understanding of science. So next slide, please. So this is just an example of one of the stakeholders that we work with as patient advocates. All of you recognize this. We work with clinicians. We work with our medical professionals. And one thing that I think most of you will identify with is I struggle on a daily basis with very well-intended clinicians who, and these are colleagues of mine often, in fact, who don't quite understand what the role is of patient engagement. They don't understand what the added value is to their practice. And this is something that has stirred, at least in Europe, a very strong movement, which we call patient or evidence-based advocacy. So the next slide is sort of a joke here, and excuse the French. We say that advocacy is a science, and sometimes you just need to use the science to your advantage. And this is a quote taken from The Martian, the movie The Martian, and where he uses science to figure out how to survive. And well, this is not unlike what we have to do as patient advocates. So next slide. Now, just honing into the evidence-based advocacy model, essentially, this is just some targeted advocacy. If you look at that Venn diagram on the right, mixed with some data that have been produced perhaps by patient organizations or co-generated with patients and partners. And then you work with effective communication to understand how you can actually advance that to a, say, for example, policy level, if that's what you're interested in. And now in the example on the left is one I use a lot when I talk to my professional colleagues in medical sciences. And I say, look, this is hard evidence showing that patient engagement works. This is a randomized controlled trial published in 2017 in the Journal of the American Medical Association. It's a phase 3 trial where they randomized hospitals, and they gave half of the hospitals iPads in which the patients could report their symptoms and become involved in their symptom monitoring, and the other half just received normal care. And here, what you see here is a survival advantage. The patients survived longer when they were able to be engaged and report their symptoms in a timely manner, and they were involved and engaged in their work. And this is, if this was a drug, this would be very attractive to market. So why aren't we taking advantage of patient engagement? So next slide, please. So this is evidence-based advocacy in a nutshell here. We've got the patient voice, basically an individual experience that we then bundle and we try and learn from other people's experiences. And then you try and build that onto in a more systematic way so that it's actually data. And then we can use it to analyze it. And then you actually build a very compelling story and some interesting data that you can then use to help decision makers reach the conclusions that they need to reach. So the next slide, please. So, of course, sharing your personal experience about your disease is a really important place to start. And there's I think this is, you're gonna have to click, it's an animated thing. There's but how do you use it? There's evidence to support your advocacy, and you definitely want to do it either quantitatively or quantitatively. You need to use some basic research frameworks to do that. And in doing so, you can greatly influence decisions in a much more effective manner than if you don't use evidence-based advocacy. So next slide, please. So just a quick pointers here is evidence-based advocacy in general. It improves the credibility of patients' organizations. It helps understand the actual patient needs in a systematic manner. It's good practice. It ensures transparency in the way that you go about this data, and it keeps your stakeholders also accountable for their actions and their input. It uses resources in a very efficient manner, and it definitely reduces waste. And generally, it has a greater impact. So next slide, please. I have a couple examples here I'd like to share with you in the last few minutes here. So obviously, most of you are involved, if you're a patient advocate, in some form of evidence-based advocacy, no matter what you call it. For example, patient surveys are a very important aspect, but you can also fight for access to treatments using evidence-based advocacy. You can point to national disparities or even global disparities, and I'll give some actual examples in a minute. This is just a list I wanted to put up there. So next slide, please. So this is a kind of a busy slide. I'm only going to point to it and show it. It's kind of a heat map. This is an example of a group in Europe called Myeloma Patients Europe. And what they did is they said, they list the countries listed on the far left of that chart are all the European countries, and they just sort of gave a scale together with patients and with the medical professionals on how good is this country at, and they had various about 25 determinants that they were scored on. And they could say, generally speaking, Southern Europe did better than anticipated, but Eastern Europe did quite poorly when compared with the Western or Northern countries in Europe. And that can point to disparities that will allow policymakers to perhaps spend more resources in the places where that's needed more. That's evidence-based advocacy. Next slide. I'm involved in this project. This is the same project I just showed you on the last slide, but expanded to include 27 diseases now, in which we're using solid tumors. This is partly a cancer-based story, also blood cancers, and lastly, non-blood cancers. So these are the benign, so-called benign blood diseases. And we are working with a much larger scale, and we have an interactive, what's the word I want? Dashboard and so forth that work with. But this is an example of literally millions of cancer patients working together to make this data available and then produce it to the policymakers to encourage clinical trial access across all of Europe in a more equitable manner. So I think this is my last example here is in evidence-based advocacy. I personally was involved in this. So I'm a kidney cancer patient advocate. And in 2018, we were greatly disappointed as a community when the European Medicines Agency refused a combination of two drugs. The patient community was very confused by this because the trial data had shown that about 10 to 12% of patients were actually cured or had very long-term benefit on this drug combination. And the question that we were really confronted with is, what can patient organizations do? Well, we didn't know where to go. The EMA was not responding to us. So instead, we decided to go to the European Association of Urology. These are the professional organization for urologists in Europe. And we asked their guidelines committee to please review the data with us. So we then went through the data from the patient perspective with this professional society. We convinced them that the evidence was very strong in favor for a patient benefit and that the guidelines should not be changed as a result of the EMA decision. So the EMA said, no, the drug is not accessible. And we said, even if it's not accessible, don't change the guidelines. The guidelines are based on evidence. And we published a joint statement together, so as a patient organization, together with the urologists. And we said, we are not changing the guidelines despite the EMA decision. Well, next slide. Well, happy to say the EMA changed their mind. A few weeks later, they changed it, and now this combination is still the frontline first-line treatment for kidney cancer in 77 countries that use the EAU guidelines. So this is an example of where advocacy was very successful. Now, the funny thing is the next slide, is the very next day, I got an email from the EMA asking me to join the scientific committee. And that was a fun moment of saying, okay, listen, they did listen to us. They did see what we were doing, and they did understand that patient advocacy has room to convince regulators as well as professional societies to change their mind. So my last slide is really just a quick overview. It's a very busy slide. It's saying that patients and patient organizations and expert patients can be involved in every element of research. This is a well-defined model. It's been published several years ago, and it talks about how and where patients should be involved in evidence-based advocacy along the life cycle of medicines, but also research in general. So thank you very much. My last slide is just a thank you slide. So I'll give the
Thanks so
word back
much.
to Noel.
Thanks so much, Rachel.
Apologies for the problems.
No, we made it. We made it. That was great. I want to remind people, if you have questions or you want some additional information from Rachel, please feel free to put that into the Q&A. And next up, without further ado, to keep things moving, I want to introduce BC Pomeroy. So I'll let you take it away, BC.
Thanks so much, Noel, and thanks, Rachel. That was great. Let me just get to my little PowerPoint here and share. And how's that working for everybody? Good? Perfect. Right on. Great. Well, thank you, everybody. And what a pleasure to be here for this conference and those folks that are here, particularly when we're talking about research and advancing inclusive research practices, something that's very important and near and dear to my heart. I am a genderqueer researcher. I am a patient. I am a parent. I am a grieving parent, having lost a child to a rare, complex condition. I currently also work in healthcare and you can't really see my gray hair, but have been in the field of healthcare for decades and currently work for Provincial Health Services Authority here in British Columbia. And I seem to find myself often working in areas where there is a tremendous amount of discomfort and opportunities for learning and innovation. I'm currently running the Medical Assistance in Dying program here in British Columbia, but prior to that have worked across the country developing equity frameworks, in particular for health research. I'm grateful to be here today. I am on the stolen lands, the Snuneymuxw people, that is just off the coast of British Columbia, of Turtle Island, on a little island colonially known as Gabriola, which I love and adore, and I'm grateful I get to work from this space and place today. So I'm going to talk about two projects that I've been involved with here in British Columbia and across Canada. And this work is really about advancing inclusive research practices that don't just generate better science, but also create stronger partnerships with patients, caregivers, and the community. And so why does this matter? Right? When we hear the term women's health as an example, many of us immediately think of a fixed category, women defined by sex assigned at birth. This framing, as we know, has deep historical roots. For decades, medicine and research operated within a binary model, women on one side, men on the other. And let's be honest, often it was men on one side and women sort of forgotten on the other for decades. This was seen as tidy, this was seen as scientific and efficient, but the truth is it was never complete and it was never neutral. This binary framing leaves out many people, for example, transgender men and non-binary people who can experience pregnancy, postpartum depression, or menopause are often excluded from studies. So conversely, some intersex individuals whose bodies don't fit neatly into that male-female classifications are erased altogether. When research is structured this way, the evidence we produce is both limited and inequitable. And this matters for sort of three key reasons. First, it matters for equity because every patient deserves to see themselves reflected in health research and care. Second, it matters for scientific rigor. When we collapse diverse experiences into a binary, our data loses nuance and validity. And third, it matters for trust. Communities who are excluded or misrepresented often lose faith in the systems meant to care for them. And across the lifespan, from adolescence through menopause and into later life, gender identity and social roles profoundly shape health outcomes. If our research only considers women as a homogeneous binary group, we miss the layered ways that gender and trauma and these care systems intersect. So when we talk about women's health today, we're really talking about a field in evolution, one that honors a historical focus on women, while also moving towards more inclusive frameworks that recognize gender diversity, intersecting identities, and lived experience. This shift doesn't take away from women's health, it strengthens it by making it more accurate, more inclusive, and ultimately more impactful. In much of health research, we still see data collected through a very narrow lens, often reduced to a simple male-female binary. This isn't just limiting, it actually creates harm. People whose identities fall outside the binary are excluded or misrepresented. That means that their experiences, my experiences as being part of those communities, aren't reflected in the evidence we rely on to shape healthcare. The result are research findings that are incomplete and health systems that continue to perpetuate these inequities. When we shift towards inclusion, we not only honor people's lived realities, we also strengthen the validity and impact of our science. So what I want to introduce you to first and foremost is Beyond the Binary, and it's a culmination of a multi-year collaborative community engaged project. This was done with people who experience or have experienced gender-based inequities, with researchers in those particular fields, and research system partners. We were tasked to address both the tension and the need for gender inclusive guidance, and to develop a nationally relevant feasible guide and resource package to support health researchers and health research institutions in their commitments to conducting gender equitable women's health research. And I was one of those folks who came into this project thinking, let's neutralize everything, they, them, everything, and quickly learned that women and children are still so incredibly misrepresented and oppressed around the world. Thus, we needed to look at this gender additive or gender inclusive model for research and healthcare design. So collectively, we learned throughout our journey that embodying and providing feedback using person-centered, justice-oriented, trauma-informed approaches is one that requires self-reflection, agility, and commitment. And together as a team over these years, we've explored how to move past binary frameworks in health research. Our approach was grounded in trauma resiliency-informed practice, recognizing the harms people have experienced in health systems and the strengths they bring into these research spaces. And Rachel spoke about that so well in the last session. So our approach, the focus wasn't just on what we researched, but how we did it. And I think that's really important when we consider inclusive research practices. We centered belonging, safety, and meaningful partnerships. To make this project meaningful, we knew the process was just important as the outcome. We used a community-engaged design, bringing patients, caregivers, and community members into the work from the very beginning, not as consultants at the end. We hosted participatory workshops and dialogue sessions where partners, both patients and those in the community and researchers, could share experiences, identifying barriers, and imagine new ways of doing research. And crucially, we didn't assume we had the answers, both those of us that were patient partners in this, but also the researchers and the programs that were represented. Instead, we co-created the questions, the priorities, and the solutions together. And finally, the project was reflective, meaning we learned as we went and adjusted based on feedback. And that flexibility was key to making the process safe, respectful, and responsive. So an example was during our project, when we think of consent and those who are consenting both to participate in the research and those who are partners, people were transitioning during our partnership. So what does consent look like when we consider those in diverse communities and we think of inclusion? People change their names, they change their identities, they maybe are transitioning their gender expression. And so how do we respond to that within our projects? And again, we did also have to extend our funding and our timelines. Again, being reflective and learning throughout, and thankfully we had great partners who were responsive to a lot of those requests. So what did we hear? This new national guide now was originally in British Columbia, it's now across Canada. The new national guide Beyond the Binary has been led by these 4 messages from members across Canada who have intersected with us as we've done this work. Number 1 is acknowledging the tension around women and how we're using that language and how it's being how it's showing up in the research that we're collecting. Address barriers using additive language approaches. So rather than just neutralizing gender and saying people who have babies or folks who are experiencing menopause, it's about saying women and folks who have cervix, or women and those who are experiencing pregnancy. So this idea of an additive language approach. Normalizing use of cisgender by the research community, so that we're not just defaulting women by actually indicating cisgender. So it's not always about identifying the communities that we're supporting, on the side. It's also how we're identifying cisgender by the research community. And lastly, this idea that language is ever evolving. Within the course of my several years involved in this project, language has changed even then. It is vital that this work be done in a continuous way that recognizes and addresses this in the work that we're doing. So out of this collaborative process came a set of tools and resources that you'll be able to find. I think the link's been put in the chat, designed to make research more inclusive in practice. We developed an inclusive demographic question guide to help researchers collect data that better reflects gender diversity. Second, we co-designed training modules for research teams on trauma resiliency informed approaches so that inclusivity is built into the way studies are conducted. Third, we created partnership frameworks that guide how patients and community members can be meaningfully involved in research design and governance. And finally, we produced knowledge translation resources that ensure findings are shared not just with academics, but with the communities that they affect. And again, I kind of go back to what Rachel's presentation was talking about, how we have this evidence-based advocacy. These tools are practical, adaptable, and ready to be embedded across a range of research contexts. And again, afterwards, feel free to contact me. And in the guide itself, there's a lot of examples of how we've done that and how you too can do that work. One of the elders in our project, Elder Sandy Leo, some of you may know, it is always best to ask people the language they use to describe their own experiences. So what were some of our learnings in actually doing this project Beyond the Binary? Language matters. The words we choose shape whether people feel included or excluded. That means both in your surveys, in your demographic data collection, whether someone's experiencing and receiving care, or within the research partnerships themselves. Data collection tools need updating. Many intake forms or surveys are not designed to reflect diverse identities, and that's a lot of work that we're trying to do right now across the country. Research teams benefit from training, so building inclusive skills helps avoid harm and enriches the collaborations that we're participating with. And partnerships improve both process and outcomes. And one partner in our team really put it beautifully. Inclusion isn't just about categories, which we often focus on in research. It's really about belonging. And so that's that project. And again, feel free to go to the link in the chat. The second one quickly I'm going to talk about is the Tapestry project, which is done by the BC Support Unit. So this brings us to that project after the Beyond the Binary. So this was one of my first projects with BC Support Unit. Gosh, it's like almost a decade ago when we started this. It's a suite of educational modules designed to help support inclusion of diverse people in health research. It is online, it is digital, and it is an iterative platform. And again, really recommend going to that link and seeing that platform. It's really quite extraordinary program. So Tapestry is designed to weave together the voices of patients, caregivers, community members, and researchers into a more cohesive and inclusive research culture in this digital space, as well as outside of this digital space. It's about capacity bridging. I know we hear the term capacity building often. I prefer to use the term capacity bridging, helping research teams across the country and beyond to embed a lot of these approaches into their work. And I'll show you a page of it in just a few minutes. And like threads in a tapestry, it's about connection. It's about bringing together diverse perspectives into a stronger whole in the work that we're doing. So this is a tapestry itself, and this is methods for supporting diverse patient engagement in a diverse world. So what does this look like in action? You'll see here again, it's about designing demographic questions that reflect all kinds of diversity that we see here. partnering with patients and community members in study design and governance, creating safer, more welcoming environments for participation. I know one of my first meetings, I was asked to go to the very hospital where my child had been quite sick and where my child had passed away. And so again, creating safer, more welcoming environments for participation. Like, what does that look like for us as researchers, and how, again, do we advocate for that as patient partners and members of the community as we're doing this work? So that was really important for us in this project. Sharing findings in ways that are accessible, not just to academics, but to communities who are directly affected. And again, kind of goes back to Rachel's presentation on this evidence-based advocacy. How do we do that if we don't have access to the results of the work that we're participating in? And really, these practices aren't complicated, but they make research more accurate, more relevant, and more trustworthy. And you'll see here, there's methods in here for those that are within the deaf community, those that are, there's a primer, those within the disabled community, rural and remote communities. Again, it's a really great resource, which was sort of what I was asked to share today with the folks that are attending our conference today. And so what is the global relevance to this work? Well, although this work was developed in British Columbia and across Canada, the relevance really extends well beyond our local context. We've presented and provided consultation in the US, Australia, UK, Europe, South America, you name it. We've kind of been everywhere sharing this work. Health research systems around the world often rely on binary categories, whether we're talking about demographic surveys in Europe, clinical trials in North America, or public health programs in Asia or Africa. The assumption of male and female only continues to shape how evidence is collected and interpreted. This creates a universal challenge. So when research excludes people whose experiences don't fit those narrow frames, the knowledge we produce is incomplete, and the health inequities we see are reproduced. I'm going to kind of say that again. When research excludes people whose experiences don't fit these narrow frames that currently exist, the knowledge we produce is incomplete. And it really perpetuates the health inequities that we see, in our healthcare systems. But this is also, I want to sort of have an open invitation, a universal opportunity. It's not tied to any single country or culture. These are approaches that resonate globally because they prioritize dignity, safety, and belonging. The Beyond the Binary and the Tapestry projects really show us what's possible when patients, communities, and researchers work together to reimagine research. These lessons around partnership, inclusivity, and co-creation are adaptable across the borders, and these are just two tools that you can utilize to support that. In other words, this is not just a British Columbia story. Really, it's about a shared invitation to evolve our research cultures together and to move beyond binary assumptions and to generate evidence that truly reflects the diversity of our human experience. And what I want to leave you with today, sort of in closing, is gender inclusivity is integral to both equity and scientific rigor. Trauma resilience-informed practice enriches that research process. Partnerships transform outcomes, making research more relevant and trustworthy. And really this idea that change is possible at every stage of research. Inclusive research isn't just about who is in the room, which is often the focus. It's about how we work together so we can gain and gather this evidence, again, to have this idea of evidence-based advocacy in the work that we're doing. And I'm going to end here with my two baby boys. This is Sven on the left and Rhodey on the right. Just want to say thank you. This work is possible only through the partnerships that we have here today. We'd love to continue learning and collaborating, and for folks just to reach out anytime if they want to have more information.
Thank you so much, BC. It's so much amazing insight and resources to take in. So please continue to drop questions that you might have for BC in the chat. I'm going to share my screen now. Uh-oh, it's not letting me more. There we go. Okay. Just switch to my slideshow. Here we go. Okay, so I'm gonna do our last little presentation of the day, and then we'll open it up for Q&A. So hello, everyone. My name is Knoll Larkin. I use he, him, or they, them pronouns. I'm currently the Patient Partners Program Officer at MISHAR, located in the US in Southeast Michigan. Identify as a patient partner also in the PCORNet precedented study. Also identify as a facilitator of patient engagement and a research staff member. I spent most of my career as a liaison between patients, communities, and academic institutions. I identify as disabled, transgender, queer, and probably my favorite identity is a parent to my 3 kiddos. So a little background about MISHAR and our program. We're University of Michigan's hub for clinical and translational research. So we're supported here in the US by the National Institutes of Health's Clinical and Translational Science Award Program. So we're one of over 60 different centers or hubs here in the US. So we bring together support for research teams, design, help to fund studies, help running studies, sharing results. And a big part of that is patient and community engagement. We don't just offer services, but we also study the process of research itself, so we can improve systems and share practices with other institutions. So our Patient Partners program really approaches engagement from a translational science lens. So we hear this word a lot and everyone's like, what is translational science? Well, it's really the study of how to move discoveries from research into real world health solutions. You can kind of think of translational science as a bridge between research and real life. So we have a discovery that might start in a lab or a clinic, but it takes many, many more steps before it becomes a treatment or a test or a tool that patients can use. So translational science is that studies that help bridge or build that bridge stronger to help get people across it and to the resources they need sooner. So the image on your right shows a spectrum of translational science. And as you can see, patient involvement is at the very center of translational science. So our Patient Partners program at MISHAR, and our signature initiative called the Patient Partners Academy started about 2 years ago. And here's our team. And I just want to highlight, it's going to let me click through. Okay, so this is Greg Merritt. Many of you may know Greg. He's actually on the steering committee for this conference. He is our co-lead, our patient partner co-lead. So our program, we wanted to make sure that we had patient leadership. So we have our faculty member, Dr. Dave Williams, and co-led by Greg Merritt. So what are we trying to do? So we're trying to elevate patient researcher partnerships, develop, disseminate a program that promotes authentic partnerships to advance clinical and translational research. So we know research teams want to work with patient partners, but they often lack training, research, knowledge, or structures to really do this effectively. We also know that many patients and families and care partners are interested in contributing to research. So our program is really helping teams made up of researchers and patient partners gain that readiness and to build sustainable partnerships over time. I love this quote from Greg. He kind of thinking about our vision here for our program is that we really hope as a result of this program that we build new tables to do research collaboratively together instead of just inviting patients to come to the researchers table. So we kind of want to focus on a paradigm shift in the way that we're thinking about engagement. And honestly, when we look back on this time, I'm hoping that we'll be shocked to learn that there was ever a time that patients were not engaged in research, that we'll think that's bizarre. So what we kind of came up with in our program to support engagement in research are a couple different components. One is called the Patient Partners Academy. So this is a training and capacity building or bridging, as I'm now learning from BC. I love that language. Helping people work better on collaborative teams. We've been offering consultations, so personalized guidance to researchers, but also to patient partner groups as well. We are launching a rapid feedback service. So this is going to provide quick input from patients, integrating patient voice early and efficiently. We've heard from faculty members that pre-award, like is a big challenge in kind of gathering your patient partners and submitting grants. So we're trying to address those gaps, grant collaborations, and maybe most importantly, we're really looking at institutional change initiatives. So how can we work within the state of Michigan, nationally and even internationally, to remove barriers and really create an environment where patient engagement is expected and supported. So I guess we wouldn't be a research institution, I know we're based here, without thinking about, what don't we know and what do we need to know before we build all these resources? So with these goals in mind, we set out to learn and listen to patient partners and researchers by doing some of our own research. So first we collected some qualitative data. And just as a reminder, qualitative data is information that we might gather to understand people's experiences, thoughts, or feelings. So instead of counting things, we're looking at themes or stories or ideas. So we interviewed 31 patient partners, 10 researchers, and then 6 folks that kind of identified as facilitators of patient engagement and research. And so, for example, on the left, you'll see this word cloud. We asked patient partners, what topic should be included in a training program for patient research partners? And you'll see things like Research 101, which was expected, and some things that we didn't expect. We heard from people that they really wanted to understand academic culture at a particular institution. So that was interesting. On the right, you'll see a summary of some of the findings from our researcher interviews. We asked researchers, what makes it easier or what makes it more challenging to partner with patients in clinical research? So for example, having that institutional structure and support was the #1 most cited thing that made it easier for researchers. And again, understanding the impact that patient partners have on research was a really big facilitator. So we couldn't stop at the qualitative data. We also wanted to gather some quantitative data. So we wanted to get a sense of what is the average patient's thought on engagement. A lot of research out there interviews people that are already patient partners. So we kind of wanted to see, let's do a random sample of patients at the University of Michigan Hospital to see what's their interest in being a patient partner. What are their barriers and preferences in partnering? So we sent out a survey to 2,000 randomly selected partners or patients last year. We found 63% of the folks responded said they were interested in partnering in research. And I promise you, we spent a lot of time defining what partnership meant and differentiating that from participation in a research study. And then over 80% of the people that wanted to partner said they would be interested in a training program. So here's just I know it's hard to read in a very busy slide, but here are the types of activities that we heard from people that they said they want to be engaged with. So sharing personal experiences was #1, reviewing patient-facing study materials. #3, creating and developing, prioritizing research topics. And then again, assisting during study conduct. We got the full list on the right there. And then I'll also say that we are currently planning a US national survey on researchers' perspectives on patients. That's going to go out in hopefully January of 2026. So we're going to do a random sample of about 4,000 selected researchers who focus on human subjects research. And our sample will hopefully be the NIH Reporter, which is a database of funded researchers. So after all of that data and work, we started building our Patient Partner Academy. And so our kind of biggest offerings, or our first offerings, are some of our training modules. So we've built this Becoming a Patient Partner, which is our introductory online module. It's going to launch next month. I will say we did all of this with patient partner feedback, faculty, researcher feedback, and staff feedback. This first module is really designed for a patient who doesn't know anything about what it means to be a patient partner, trying to kind of provide them with an introduction. We're also planning additional modules focused on different special topics like how to be a patient mentor or how to participate in reviewing grants or a study section. And we are also well along the way with our kind of Researcher 101 module. But we also want to think broader than just online training modules. So we're also planning to offer communities of practice for researchers and patient partners, more innovative learning models where we might have combined partner and researcher cohorts, and then skill building workshops. For example, something like, storytelling for impact. Here's just a quick little screenshot of our online training module. We built this in Rise. So that's been kind of a fun process. And then we also heard from folks that there were a lot of topics from researchers as well as partners that patients and researchers wanted more resources about. So we've been kind of exploring and discussing what should we build first. So we have some infographics. The first one is just kind of what is a patient partner? And we also include a lot of different terms because we know that not everyone calls it patient partnership. So we kind of talk about what does a partner do? Who are they? We also have one that's this was very highly requested, was something about understanding the difference between a patient research participant and a research partner. So we worked with our cancer center, and it's a much longer, bigger, but this is just a quick screenshot of that, comparing the difference between the those two modules or those two concepts. And then finally, we've been exploring and discussing differences and similarities of patient engagement and community engagement in research. So we're also creating a infographic for that. And again, our interest in classifying that is really just to emphasize the importance of both to patients and communities and researchers, that both of these things are important, and to kind of help folks explore which approaches may be most useful across various points in a research study. So that is it for me. Because we have so many resources in development, if you want any of these resources, I created a brief form for folks to fill out, and when they are launched or go live, I'd be happy to send them to you, including our data from our research studies. And again, if you want to partner, co-create, collaborate, commiserate about challenges, or just learn more, feel free to contact us, Mishara at Patient Partners. So I will stop sharing my screen. Thank you so much, Dawn, for posting that. And I'll invite Rachel and BC to come back on. And let me see if there are, I did have two, let me check our Q&A, but now would be the time if you have questions that you would like us to ask. I have flagged a few that kind of came up along the way. Maybe we can start with those and see if folks add any more. Let's see. So the first one I had was for you, Rachel. Somebody had mentioned, I think this person may have had to hop off the call early, but they were wondering, they loved all your slides, but they were wondering, for some of the advocacy presentations they do, for knowledge translation in communities or with patient groups, a lot of times like stats and graphs and citations aren't always helpful. So are there recommendations that you'd have around doing a presentation around patient advocacy for a community group?
I mean, no, that's a great question. Absolutely. And it's something that we all face, right? So I think we can all identify with this. I think the human story really speaks, and that narrative is a great way to kind of clothe data and make it more palatable. It is daunting for the average citizen who's not, highly scientifically, hardened at this point to grasp a lot of things. If you look at Kaplan-Meier curve or any of these curves or graphs, they just look like they make it actually inaccessible. And that's a pity. That shouldn't be the case. So in my former organization, we put a lot of effort into infographics, not only because it helped tell the story about with numbers and made it a little bit easier to understand, but also remember. But it was also very sensitive to the cultural differences and language differences that people have. So we found that if we had an infographic that was properly prepared, we could use it in almost all of our different societies and our different countries that we work with. And I work in a country where we speak English and Dutch pretty interchangeably, but most people have problems with English if you're not if you're not happy to be born in an English language speaking. So we try and just put everything into pictures. Pictures say 1,000 words, right? So you can actually display a lot of complex ideas just with very simple graphics. And I think we all need to become a bit more proficient at that and take the time to learn how to do that. I admire good graphic designers. They do a fantastic job. Full respect.
Yes, amazing. Thank you so much for that, Rachel. The other question that someone had was for BC. So let me try to frame this correctly. Do you have any sort of comments on like best practices in general for capacity bridging for inclusivity on research teams? Like there are some like big picture, takeaways that, if you were gonna get started on thinking about inclusivity on your research team.
Yeah,
You're on
there,
mute.
I got it. Yeah.
Yes.
Yeah, I mean, obviously I referred to the Beyond the Binary guide. I think that's actually a really great place to start. It really talks first and foremost, I think like a lot of equity work and a lot of work around inclusivity, whether it's at point of care, designing systems or in research. I think one of the biggest things that we can do is really have that sort of personal reflexivity. Like who are we showing up as in our work? Who are we showing up as with patients or in the community, and having some of those pieces around reflexivity. I think it's really hard, to think of inclusive research practices if we don't actually know where we are on that social ladder or, within our own space. Here in BC, we do a lot of work in Indigenous communities, and that is one of the biggest things that we look at. The other thing too is I think it takes time. Research traditionally takes a long time, and we're used to that. But for some reason, in research, we still think that doing patient partnerships should be overnight. So it's kind of different with the culture. So again, knowing that our funding models, talking to those who are funding us, and looking at our traditional project management tools and structures, that it's going to take a little bit longer to do this work. And those are sort of my two beginning points, but I really think we can't give what we don't have. So we need to be looking at ourselves first, showing up in well ways, being able to respond in well ways. And from there, communities will naturally lead us into the places and spaces that they'd like us to, or where they feel those priorities are. But now
Thank
you're
you
on
so
mute.
much. We're gonna play the mute game. Someone had a question. I think this may be for both me and UBC, but will these resources or trainings be available or free to all? The answer is yes. In fact, we're hoping to explore ways that we could actually compensate patients or partners for doing some of the trainings. So yes, it's important to us that they are as accessible as possible and free.
And
And I
same with
assume the
ours. They're,
same.
they're both, yeah, they're both accessible and free for folks to utilize for sure.
Okay, amazing. This was for, I think, all of us. And does anyone have any explicitly anti-ableist or anti-classist sort of partnership resources for researchers? I'm trying to think of.
I think that's great. I think anti-ableist, again, sort of reflecting on my experience with both the Tapestry Project and Beyond the Binary, that I'm not going to say it's new because anti-ableist language and behavior has been around since the beginning of time. But I think folks are just learning and just understanding what that means in reflection for how they're showing up in this work as researchers. So I don't, like, to be honest, I don't think we're there yet in having some good resources for that. So whoever asked that question, and those that are sort of in the webinar itself, super open to learning more about that and how we can better support that work. But I think we are at the beginning stages, I think, of looking at anti-ableism, what that means, language that's important, for that work, and how we show up for that community. So I don't think we're there yet at all. We did have a couple patient partners within our Beyond the Binary group that were with anti-ableist organizations. And I'll see if I can find those links and pop them into the chat as well.
Yeah, and I think to me, I'm not aware of any right off the bat, but I think some of the things that you talked about, BC, around like trauma informed, I think that's another
Mm.
thing that we're really thinking about, and maybe capture some of that. But I also know that I think one of the challenges we see with researchers and healthcare providers is ableism is just so embedded into medical care, that can become very, very challenging to shift that sort of structure, even in interactions in team meetings, right? I see a lot of that play out. So that's a really, really important resource. And please share, whoever asked the question, or if anyone has resources in
Yeah.
the chat, please do. Oh, I'm bringing forward, somebody mentioned something called disrupting ableism. So we'll see if we can find that.
Yeah. And Isabel has one too from Solutions for Kids in Pain. And it's kind of tongue in cheek when I say, of course, the pediatric world is on it.
Yes. I'm looking through the chat to see if there's any other questions. Let's see, somebody said, are you aware of any patient partnership competency frameworks for research teams and or also patient partners?
Oh, Beth, we haven't met, so you don't know me yet, but I kind of challenge the thinking there. That is very sort of colonial privileged. Um, we use a lot of colonial privileged frameworks and that language in our work, and so I say that with much love and gratitude for that question. I kind of feel like patient partners are already coming to the table with a tremendous amount of competency. Are there opportunities for us to capacity bridge? Kind of what Rachel was speaking to in regards
Yeah.
to some of those skill building and just language and terminology, and how does the grant work, and what language do I need to put in there, and sex and gender based analysis. And so I think those are those pieces that we can bridge capacity. But I really strongly believe that patients and families come to the table with so much competency
Agree.
already.
I couldn't agree more. There are of course resources where the frameworks do exist. If you are really interested, you can check out UPATI in Europe. We have a very good framework available. I think there's some North American sources as well. There's no need to reinvent the wheel, in other words.
Mhm.
Time for maybe one more. Somebody asked in the chat, which could be a whole session in itself, what we all think of the term interested people or interest holders versus stakeholders. I know sometimes we're moving, people are thinking about moving away from that term stakeholders and
Yeah,
looking at other
agreed.
language.
Yeah, agreed. And I think also, when we're involved in the design of these research projects, again, kind of going back to one of our partners, and to this amazing knowledge keeper, Elder Sandy Leo's, like really ask folks, like, what do you want to be called? I mean, I used to say queer researcher, now I'm a gender queer researcher. I mean, tomorrow it might be something different. So it's just, ask the folks that you're partnering with how they want to be referred to. And I think that goes the same with when we're looking at getting participants on the other end of research. Same sort of thing. The community knows how best to reference themselves in the work and partnerships that we're doing.
Let's see if there's any last, I missed one. Thank you for pointing that out. There's one more question. I think it was directed at me, but feel free to others to jump in. What did it take to get buy-in and momentum? We need to wrap up. Okay. For this work. And I very short answer is we're still discovering that. I think I'm working in an academic space. And so in order for us to, we do need buy-in from researchers to utilize our services. And I think it's complicated. And so I think we're doing that by engaging as many patient partners as we can and researchers in the programs that we're developing, so that hopefully those interest holders see themselves and their needs reflected in what we build. So I'll end it there and hand it back over.
Thank you very much. What a learning experience. And just off bat, I am indebted to Knoll, Rachel, and BC for your generosity, for your knowledge share, for just saying, please reach out. We are in this together. But my key takeaway from this session is that language matters. And that it is forever evolving. I think it was BC or Rachel who said, I'm this today, I'm that today. I've been at it for 19 years, and I'm just amazed at how I keep learning new language. And I think it is an invitation for us all, especially health providers, researchers, those people. We need to keep relearning. And my final reflection is that research knowledge production should be a living, intentional, and dignity enhancing enterprise. With that, I want to invite us. We will not have a break now. We're going to move right into the next session, which is Ask Me Anything, which will be a session with two researchers about how to engage patients in researchers' research. I don't know if that's English. And so please let's move over to that session. And thank you all for a very beautiful day today. Oh, yeah.